I'm Paul Lukac. I'm at UCLA Health. At my clinical training is as a pediatrician. I always wanted to be a doctor, like many doctors say. And I went to Columbia in New York and ended up going into pediatrics. As I said, I'm from Chicago originally, so I did my residency training in Chicago, and then I worked at the main children's hospital there at Northwestern. And that's when I got into informatics, like the optimization of our healthcare record there. And I was very intrigued by it. And then my wife and I decided to relocate to California, which coincided with the decision I made is that I wanted to go to business school to just add a skill set that I was always interested in. And then it was really in business school that I really got into healthcare, data management, and analytics and whatnot, and was introduced to some of the AI vendors and startups and whatnot. And coming out of that, I did a clinical informatics fellowship at UCLA, and then that's a 2-year accredited fellowship, and I've now been in my current role for 2 years. And so my main role is as a director of applied AI, and then I'm also an ambulatory physician informaticist. The physician informaticist is like optimizing our electronic health record and doing things like note templates and best practice alerts and whatnot. And we use Epic at UCLA. And then the other part of my job is a director of applied AI, which is constantly evolving with the way things are evolving in healthcare regarding AI. But I co-lead our AI council at UCLA Health, which is responsible for governance of all AI models that will be deployed for actual clinical or operational use. And we are an approval council, so we can approve or deny use. Very rarely would we deny something. And then we also give plans for like maintenance and monitoring. And then as part of that role, I'm heavily involved in our uses, or at least our roadmap for use of Epic's GPT tools that they're releasing, as well as evaluating vendor solutions and determining strategy overall for the hospital system.
So, so it sounds like you started to get into AI business school. Was data and technology always part of what you wanted to do? And I'm curious how, whether you're spending more time on the IT system side of informatics or the ML data side.
No, it was not always something I would say that I wanted to do, but I was always like into like mathematical things. Like I was a minor in college in math. And then uh, growing up, I was always like obsessed with statistics. I'm a big sports fan, and I was one of the kids who would like read the newspaper, and I loved looking at like baseball statistics. So maybe that factored into it. But like I said, it was really in business school when I got introduced to this one health tech startup that was local here. And what they had is they had an algorithm to build cohorts for clinical trials. And I was really just fascinated about it because another part of it was they obviously a lot of clinical trials are around cancer treatments. And I myself had an unfortunate history of cancer. So that really resonated with me. And to be honest, at that time, I didn't really know a lot about, healthcare data and what we can do with it and informatics, but I'm always a continuing self-driven adult learner. So going into the clinical informatics fellowship was very important. I have some great mentors at UCLA Health. And really, I would say a big turning point was when I started my new role in 2022. It was about 6 months before OpenAI released ChatGPT 3.5. And then everything changed when they released it. And it's been very fast paced and a lot of progress has been made. And there is more excitement for something in my field than I've ever seen, in the 2 decades that I've been 15 years that I've been in medicine.
Yeah. And so what has that journey looked like at UCLA? Establishing this health AI council. What has been your role in getting that started? And, what are you doing now day to day with that as far as governance and quality
Sure.
AI station?
Yeah, that's been an evolution too, because there is not like any sort of great framework out there or like establish guidelines for how to evaluate an AI model and make sure it's safe and whatnot. And we look to like the federal government for guidance on these things, but that's not quite there yet either. The FDA, for example, which we expect to monitor these sort of like drugs and medical devices, really they don't have a firm policy in place. They monitor AI clinical decision support software as a medical device, and it's more guidance. It's not like they have a requirement that you get an algorithm approved for use. So institutions are left coming up with sort of their own pathways to governance of AI models. We're generally guided by the term responsible AI. So these are like important principles like transparency, accountability, et cetera. And, we built the UC system. I think in 2021, they had a presidential working group that produced a very long on the UC stance towards responsible AI. And so that is what guides the council. And so based on what that said and the principles they embraced, we tried to figure out a way to evaluate models in both a quantitative and qualitative fashion. And what we ended up doing is there was an AI risk framework. It's called the Ethics AI Toolkit that was created out of a group in San Francisco that was not specifically healthcare, but it was created by some government adjacent and other organizations. And we really liked it because it aligned with responsible AI principles. And it also gave us a way to evaluate models in a quantitative way. And so with that, we look at different areas. Not only do we look at like how well it's performing, but we make sure that it's low risk for bias, or if there is a risk, that we're mitigating that we look at things like any like vendor risks that we might be concerned about, et cetera. So we establish that process, and we tend to engage stakeholders or model developers a few months before their model is going to go into use. We gather some very standard information about their models, kind of like a nutritional fact sheet with information so that we have that available to anyone who needs it. We have a committee that reviews all of this and speaks with the developers in a presentation. And then we make our final decisions, which usually is an approval of a model. Sometimes we recommend or ask for some follow up analysis or something like that, but it's worked out pretty well. I will say the one caveat is this is really good for non-generative AI. So those are like an AI model that maybe is just like a predicting something like your risk of having kidney disease or getting sepsis. Is very different from generative AI, which is producing totally new text or information. And I don't think anyone has really figured out how to wrap our heads around generative AI yet.
So then does that mean the Health Council is exclusively looking at non-generative AI solutions
No, we do look
or
at both, but well, I would say that since it's very early on, we currently only have one use of generative AI, and that one was from Epic. And the way we looked at that is very different. It's kind of like the way you would just evaluate like a human, like a clinician. Like you want to make sure that what it's saying makes sense. And that's like, to be honest, it's been more like subjective feedback from end users. And it's also moving slowly in how we use it. So starting with a few small number of providers who are willing to like be very vigilant and provide good feedback, and then expand slowly from there. There are things that we can monitor that are more like traditional, like how often are they using this versus um, is this like improving their efficiency? Is it decreasing time on whatever on that specific task the tool is meant for? Those types of things. But it's not. It's very different than than doing that process for non-generative AI. There are
that
working
makes sense.
groups that there are working groups, of course, that are actually trying to come up with strategies to do that. One is CHAI, which is the Coalition for Health AI, which has kind of been stamped as like probably the healthcare standards releasing body. And then There's one called Valid AI, and that's was started at UC Davis, and that one is trying to come up with some framework or recommendations too.
So, so many questions. You mentioned bias in the models and relying on end users, like the generative AI to, I guess, really point out what bias there might be. What do you see as the biggest challenge when it comes to identifying bias? Is that do you see it in how the health system is implementing the solution, how providers are adopting it, their behaviors around it, or the actual model itself? Like, what do you
Yeah,
consider?
I think there's three ways that bias comes into play. And one is a element of like historical bias where it comes from the data itself. Like maybe we're not using the correct data or we're using a proxy variable that we shouldn't be. A good example, and maybe people are familiar with, is the Zayed Obermeyer article from I think 2019 that was got a lot of coverage because it was a risk management model that predicted anticipated resource allocation for like sick patients over the following year. And they found that it under allocated resources by prediction for Black patients because they used an inappropriate proxy variable, which was the amount of money that was spent on their care in the past. And we know that Black patients have less, money and resource allocation for a variety of reasons. So it's just not appropriate to use that. And it skewed the predictions were not good. And this was used by millions and millions of providers and payers and whatnot. So that's one way, is something that's like baked into the data. Another way is like through a technical aspect, like it could be the model itself that is introducing bias. Maybe the data is that's feeding the model is not representative of the population that the model is going to be used on. And then the third element is the workflow, of course, the other end where you, it's it's a very dynamic, and a model may work well and be totally bias free when you're testing it on existing data, but you never know what's going to happen in the real world. It would contrast that with, say, like a medication. Usually when you go through clinical trials and various, phase one, phase two, phase three, it probably will work the same in the real world. But there's this whole new element of how people react to it, AI models in the real world, that kind of clouds the picture a little bit. Did that
So,
answer the question, or was there
yeah,
a second part to that? Yeah.
well, I probably have 10 more parts, but one particular is around provider adoption and behavior. I know that some of your work has looked at that. Is that fair to say? How providers are being
Uh-huh.
technology.
Yeah.
What do you consider the biggest challenges as far as provider behavior and just, whether it could be related to workloads, it could be related to, um, I don't know, change in general and using new solutions or trust of new technologies that aren't yet necessarily proven. And to your point, it's constantly evolving.
Yeah. It's a good question. So historically, I think that our AI models at UCLA Health came organically from like a specific desire or ask, right? And so an example was our nephrologist wanted to predict the risk of end stage kidney disease over the following 2 years for their patients. And from that perspective, it was well planned. They knew what the workflow was going to be. There was great adoption and buy-in for it. So those kind of things go quite smoothly when they arise organically and there's a group of people who want it and there's champions. I think it's a little different now because these are a lot of the things that we're seeing that are coming in from a generative AI perspective. It's not so much that it's coming from a, a demand for a specific task, but it's something that we're going to bring to the providers for a more broad or general task. And it's always difficult, especially at large institutions, to change workflows and to get buy-in, especially with the numbers we're talking about. Because if the one of the most exciting ones is ambient listening documentation, and these are the the vendors who record patient doctor visit and then it writes their note for them, right? And this is something that could potentially be used by, I think we have like 3 or 4 thousand providers at UCLA. It could be used by all of them versus our nephrology department. With their model, it's like 40 or 50. So keeping tabs on that is a lot different. And I would say there's a lot of decision making that goes into that when you have that volume of providers. Like it's not, it's not free. Where do we want to, who's going to use it basically? Who's going to be like a power user? Who should we make the investment in? Who's going to pay for it? Whatnot.
Yeah. And so actually when you're making those decisions and you're looking at new technologies, what are the factors that you weigh more? So like are you, for example, weighing the risk of like we talked about, real world data input, or are you
Hmm.
weighing, or responsible AI privacy issues, or integration interoperability? What comes to your mind is the most important
Hmm.
aspects too?
Yeah. So I think at UCLA, just speaking for UCLA, we're a little bit more conservative and we like to see the other institutions have worked with the vendor or have positive results from working with that vendor before we make a move. So if like on that technology adoption curve, we're not the first group of people, maybe we're more in the early adopters. So I think we just like to see success elsewhere before we dive in. And then the other big thing to consider is I speak with lots of vendors that have very like interesting solutions or uses for their whatever their algorithm or model is. But we also need to find need to find a need and somebody or a department who is actually going to be very excited to continue using it because we can invest in something and deploy it, but it's not going to work unless they want to integrate it in their workflow and they think it's going to be useful and what have you.
Yeah. Is there what are the challenges or points of pain with integrating into existing workflows? So, most providers are using Epic or Cerner or EHR, and they sort of determine whether new technologies can be adopted and integrated to a certain extent. Would you say? Uh, so, what are the biggest challenges to bringing in a new AI solution, whether it comes from within UCLA, maybe, I don't know, I'm assuming someone needs to
Yeah.
develop it within UCLA or wider.
I think the biggest challenge is
What
determining if the investment is worth it. Like there's going to be a return on investment, which I don't think anyone does a good job of. And what we don't want to do is we don't want to add more expenses into healthcare, which we know is already we're not spending money as well as we should be. So that's something I think we need to get better idea of how to do that and forecasting if this investment is worth it.
is that and what does that have anything to do with maybe how or why there's a focus on ambient listening technologies and solutions that maybe don't require much of a change in adoption?
Yeah, I mean, we're all hopeful that ambient listening is going to accomplish, most of all that it will free up time for physicians to talk directly with their patients rather than writing on a computer. And then that will also mean that they have to spend less time taking notes after the visit or quote unquote pajama time after hours writing notes. And we know that physicians are increasingly experiencing burnout. And so we're very hopeful that this will help with that. But we have to do that correctly. We don't necessarily want to then fill all their free time by stacking their schedule with more patients, right? So that's something that we have to be mindful of. At the same time, these are pretty expensive in their current forms. So if another thing to consider, and I know some institutions have been doing, is if a physician wants to use that, they have to maybe agree to add a patient or two to their schedule. So it's a balance, but I think for that one, we're mainly hoping that at UCLA that it will help, physicians and decrease their burnout and charting burden and allow them to spend more time directly interacting with their patients.
Yeah, so that's such an important point. So, technology should help address pain points and in AI either increase productivity or reduce risk or maybe optimize clinical decisions. What are you, as part of this health AI council, are you evaluating things like how these solutions affect burnout and productivity and these other?
Yes. We're just starting to, and we're actually nearing doing pilots of two ambient documentation companies. And so we're designing how to do that specifically for this one. So we can definitely track those like hard metrics, which is like time spent in chart and time spent writing notes. So we can do that. But on the other side of things, we're definitely going to do frequent surveys and ad hoc meetings with end users to assess those things like burnout and whatnot. I will say that some of the generative AI tools that are geared toward physician burnout, specifically the Epic's first one, which is I would try not to get too much in the weeds, but when you send a message to your doctor in the online patient portal, right? And the doctor responds back to you. So Epic's use case was they used GPT to create a response, like an automated response that the physician has to review, and they can choose to send that back to the patient. So it's not really saving time. I think all institutions have shown that it's not really improving our turnaround and our message time. Even though that's the case, though, physicians seem to feel like the tool is helping them and they feel like it's saving them time and they feel like it's decreasing their cognitive load and their workload. So that's another thing that's very interesting is we maybe shouldn't necessarily expect efficiency gains at first, but it is very important to understand those subjective benefits from the end users.